Hello class. I'm just going to talk about some of the important key points in week 4. First of all, I'll just point out some important facts regarding chapter 10 in your Olson book. This week assigned reading is on flow rates and durations of enteral and intravenous infusions. As you know, we give fluids to our patients through various routes, and fluids can be given slowly over a period of time. We can give them via veins, as in an IV, or we can give these fluids through a tube in the alimentary tract, known as enteral feedings. When we provide this fluid per a certain flow rate, we continuously assess our patients to see how they're tolerating these fluids, and we do monitor precisely to make sure the patients are tolerating the type of fluid that is given, and just watch for any signs of complications that might arise. As you can see from this first picture on the slide, it's a patient with a nasogastric tube, and as you can see, that tube is down in his stomach, and he's getting some kind of nutrition through a tube feeding, okay, at a particular flow rate. And the next picture is an example of a PEG tube, which stands for a percutaneous endoscopic jejunostomy. And many times our patients cannot take food on their own, or if their upper GI tract is not functioning properly. So we want to provide the patients nutrition. And many times an IV just doesn't do it. It may give hydration and provide hydration, but it really doesn't provide the necessary calories that our patients need. And in order to do this, it involves passing some kind of tube through the intestines, either through the mouth, esophagus, or even an artificial opening. And this is the way we provide what we call an enteral feeding or tube feeding, okay? And this figure 10.2 is just one example of one of those tube feedings, you know, and this one has to be performed surgically, okay, to get to the spot where that nutrition is provided. And this type of enteral feeding is a long-term feeding, which was inserted surgically or laparoscopically through the wall of the abdomen. And this one obviously is reaching as far as the jejunum, okay? And these are pretty much sutured in place, and are just kind of assessed to make sure they're in the right place before we begin any type of nutritional feedings. These enteral feedings can be given continuously over 24 hours, or they can be ordered intermittently, where you might give a certain amount of fluids or nutrition over shorter periods of time, but we may administer to the patient several times a day. And some of the common solutions could be something like Boost, Compliant, Ensure, Isocal, Resource, and Sustacal. And we do give these enteral feedings through a pump, and given to the patient by a precise order that indicate a certain volume of fluid to be infused over a period of time. And of course we call that a flow rate, just as what we call a flow rate when we infuse a certain amount of IV fluids to the patient. An example would be tube feeding could read Isocal 50 mLs an hour via nasogastric tube for 6 hours beginning at 6 a.m. So that's how you might see an example of a certain order written for your patient. And this is just obviously a very tiny patient, an infant or pediatric patient who is receiving enteral feedings via the pump, okay? And obviously we can provide this same type of nutrition to our pediatric patients. As I said before, another type of way in which we might provide fluids to our patients is through IV solutions. And this picture is an example of a IV solution. Okay, and this one happens to be D5 in water, and an IV solution means that we're giving this fluid intravenously through the vein. And we give a variety of fluids through the vein. We may give blood, we may give a water containing nutrients, may give electrolytes, minerals, and of course specific medications that are ordered for our patients. It can replace lost fluids. For instance, if your patient with hemorrhage, if your patient is having excessive amounts of vomiting and diarrhea, IV fluids may be the way to go for your patients to prevent serious electrolyte imbalances, as well as to prevent the patient from acquiring dehydration. Many times our patients are on maintenance fluids, and they help sustain normal levels of fluid and electrolytes. Again, as with enteral solutions, IV solutions can either be continuous or intermittent. The continuous type may replace or maintain fluids or electrolytes, and an example of an intermittent IV infusion may be an IV piggyback medication, such as a replacement of potassium, electrolytes, or even antibiotics, or we may give an IV push medications through the vein. Intermittent peripheral infusion devices, a patient may have what we call a saline lock in place, which is there to use and maintain and provide venous access without actually having an IV fluid running, but just in case we do need to provide fluids or an IV medication, that access is there. That should be continued to be assessed, follow hospital policy as to how often those saline locks should be changed, and to flush them according to hospital policy, so that if they are needed, the IV access will be patent. Again, when we talk about flow rates, we're either discussing drops per minute or else milliliters per hour, which we can be provided to the patient via a pump. We still want you to learn how to do drops per minute, because for some reason, if you happen to have a patient being visited by a home health care nurse and there is no pump to infuse either a medication or IV fluids, it's good to be able to calculate how many drops per minute we would run that fluid. But our mLs per hour is provided to us or to the patient via a pump. Okay, and our pumps have become a lot more sophisticated, that they can even provide medications or fluids to the tenths, and some of them even to the hundreds. It used to be that they could only provide fluids per whole numbers. So it's just important to know how your pumps work so that you can safely provide your patients those fluids or medications that have been ordered by the physician. IV solutions come in various types, and this again is an example of an IV bag and a label. This happens to be 5% dextrose injection, which is a bag containing 1,000 milliliters. A saline solution, for example, would be sodium chloride, NaCl, and there could be various concentrations of that particular type of salt solution. One common one is 0.9% sodium chloride or normal saline. There's also half normal saline, which would be indicated by 0.45%. And then, of course, there's quarter saline, which is 0.225%. Most solutions generally contain dextrose, saline, or electrolytes. When we talk about D5 in water, as demonstrated by this PowerPoint slide, what that says is it's 5% dextrose with 5 grams of dextrose dissolved in water to make each 100 milliliters of the solution. Another example of a IV solution would be lactated ringers, which contain electrolytes, potassium chloride and calcium chloride. It's important that when you look at the label of an IV solution, you know the difference between the letters and the numbers. The letters indicate the solution, and the numbers indicate the solution strength. This is an example of 0.9% sodium chloride, very common IV solution. It is also considered to be isotonic, and so we would infuse this solution for a patient that may be somewhat volume depleted, and a lot of times this is a diluent that we may use to provide our patients antibiotics. The following slides are again examples of intravenous fluids. This one is D5 in half strength with 20 milliequivalents of potassium chloride. That's why it's always important as nurses when we're assigned a patient and they do have an IV infusing. The first thing I like to do is check that IV fluid to make sure it's the correct solution and that it is infusing at the correct milliliters per hour, and of course assess the IV site itself. And I also like to know when my IVs were put in and obviously what size cathetron was used. Usually that's marked on the IV. When I start an IV on the tape or on the dressing, I'll date when the IV was started and what size cathetron is in the patient. So it kind of gives the nurse an idea as to when she might have to, restart the IV according to hospital policy. Okay. The next one again is 1,000 milliliters of D5 in half strength, and the half strength is written as 0.45%. And this is an example of 5% dextrose and lactated ringers, 1,000 milliliters. And this could be a 500 milliliter bag of D5 quarter strength. And the quarter strength sodium chloride is written as 0.225%. And this is just an IV, a primary IV line. This is just showing you the parts of the IV bag all the way to the patient, including the tubing and what that tubing consists of, the drip chamber, the roller clamp, and the IV tubing itself, and exactly where that IV goes to. With the equipment, what's needed obviously is IV solutions, the IV tubing, the drip chamber, and at least one injection port, and a roller clamp. And the roller clamp is what kind of regulates how fast the IV will infuse into the patient. The tubing actually connects the IV solution to the hub of the IV catheter at the injection site or the infusion site. And this drip chamber right here, as you can see, there's a drop coming down. This should not be filled up completely, so you can watch how these drops kind of drip out. It allows you to count the number of drops per minute that the patient is receiving. That would be the flow rate drops per minute. And you could adjust that drips by the roller clamp, either rolling it upward or rolling it downward. The drop factor is that has to do with the tubing. So many drops per what tubing you use equals 1 milliliter, okay? And in order to do a dimensional analysis calculation, you need to know what type of tubing you are using on your patient, whether or not it's 10 drops per ml, 15 drops per ml, 20 drops per ml. That will help you calculate the mLs per hour or the drops per minute. Again, when you're setting up this type of apparatus with the gravity flow, but obviously we don't put our IV solutions to gravity. We always put them on pumps to make sure that we regulate the flow rate precisely. You always want to make sure you follow the proper procedure to eliminate all the air in the tubing before you actually connect it to your patient. And the IV solutions that are hanging and infusing, no IV solution should infuse more than 24 hours. So even if the bag is not completely empty, you would change the bag and usually the tubing along with it, okay? Because obviously that presents a media for bacteria. As I said before, knowing how many drops equals 1 ml with the types of tubing that you're using. Another type of tubing, you might use 60 drops equals 1 ml, and that would be your microdrops tubing. And the flow rate can also depend on the relative height of the IV bag and the infusion site. So that's why we use IV pumps and controllers to regulate that flow rate much more precisely. Because if you hang this bag higher without having it on a pump, it's going to infuse faster into the patients. As I said before, there are many types of electronic infusion pumps. There's volumetric infusion pumps, and sometimes your patient after surgery may have a PCA pump or a patient-controlled analgesia pump, where there's a pump and a control pump button that the patient can actually regulate how much pain medication that he gets. But obviously that will have certain limits set on it so the patient doesn't overdose himself on a medication. Your pumps more precisely regulate that flow rate, and they can also detect an interruption in the flow. For instance, if your patients would bend their arm or if the tubing would get kinked, it would be able to detect that there's a constriction in the tubing and the patient isn't receiving that particular fluid. And what happens is it sounds an alarm. It will also alarm when the solution finishes, and it's kind of like a built-in computer, which it will give you how much fluid has infused into the patient, and will give you a time remaining for how long it will take for the infusion to finish. The smart pumps nowadays have a storage of libraries of safe dosage ranges that help prevent the user from keying in an unsafe dosage of a particular medication that the patient is to receive. As I said before, there are these PCA pumps or patient-controlled analgesia pumps, which are self-administered pain-relieving drugs. And those orders are pretty much predetermined by the physician, so the pump is programmed accordingly, and there is a lockout device in the pump, so the patients cannot overdose, okay? As we continue to do dimensional analysis problems and calculation for infusions, the components that we need to know is the flow rate, volume, or duration. Usually we know 2 out of the 3, and usually one of those values are missing, okay? Pumps measure flow rates by milliliters per hour, okay? And usually there's a special type of tubing that goes with each of those specific pumps that are used in your particular facility, okay? And this is just another example. This looks like a microdrip tubing, and this is tubing with the drip factor, just kind of showing you a close-up look at that. This is that microdrip tubing. 60 drops equal 1 milliliter, so you can see how tiny those drops would be, okay? And these are examples of the macro and the micro drops. 10 drops per ml, 15 drops per ml, and 20 drops per ml. Those are usually the most common types of tubings, and how many drops equal that ml. And then, of course, your 60 microdrops equal 1 ml. And this is the volumetric infusion pump that I was talking about. And then these are these PCA pumps. And as you can see, the patient has access to the control button where they can give themselves something for pain. But as I mentioned before, there is a lockout button and the patient can't keep hitting that because they could accidentally overdose themselves. This is an example of tubing that would represent 10 drops per ml. And this is again a 500 milliliter bag of D5 water. So that's pretty much the information on enteral and IV solutions. Just wanted to kind of talk somewhat about fluid balance, proper hydration on our patients. Many of our patients do have problems with fluid and electrolytes, and that's why it's so important that we accurately measure intake and output. And fluid intake is a fluid that obviously enters the body orally or parenterally. If our patients have IV solutions, if our patients are drinking or either getting enteral tube feedings. And then, of course, fluid output would be anything that leaves the body. That could be urine, sweat, liquid stool, emesis, or any other kind of drainage. For instance, your patient had some kind of surgery and they might have a drain that's kind of collecting the drain from the area or the wound. That would also be part of output measurement. And many times the physician will calculate a certain amount of IV solutions or enteral feedings depending on how much the patient puts out, just to replace the fluids that are being lost. And so I just wanted to point that out, that sometimes you might see it ordered that way. I think it's also important to talk about the three types of solutions: hypertonic, hypotonic, and isotonic. Isotonic is probably one of the most understandable types of solution, and really what we're talking about here is a relationship between a certain fluid and osmolarity, okay? And isotonic solutions are used to increase extracellular fluid. Say your patient is dehydrated, say your patient's blood pressure has dropped, because the blood composition, the osmolarity of the blood is very equal to isotonic solutions. That's why when a patient is given an isotonic solution, the fluid stays within that vascular space and it increases vascular volume, thus helping to increase our patient's blood pressure or to help replace vascular volume that may be lost through hemorrhage. And of course, one of the most common ones is 0.9% saline or normal saline, or D5 in water, lactated ringers, or D5 quarter string, 0.225%. Your hypertonics are a greater concentration of solutes on the outside of the cell, and your hypertonic cells have an excessive amount of extracellularly, and water is out of the cells, so you want those cells to shrink. Hypotonics are used when the cell is dehydrated and fluids need to be put back intracellularly, and we might see that happen in someone who develops DKA, and you probably learned about that with your diabetes lecture. Patients that might develop what we call hyperosmolarity or hyperglycemia, patients where they have extremely high blood glucoses and develop the 3 Ps: polyuria, polydipsia, and polyphagia. So you would use a hypotonic solution to treat that. So just asking you to review that. An example of your hypotonic solutions would be a 0.4, 45% or half strength, or a 0.225 or a 0.33%. And your hypertonics would be a D10% or a D5 3% solution. So I just wanted to point that out. You should be learning somewhat about these types of solutions in your lab. I'll try to bring you a handout for this to just kind of help you understand and show you examples of these types of solutions and when you use them. Because it's very important as a nurse that as we assess the IV fluids that your patients are getting, that you look at that solution and say to yourself, why is my patient having that particular solution infused? What is the goal here in providing this patient with this type of solution? So this is pretty much all the information from Chapter 10 in your Pearson. And now I'm going to talk to you about your prototypes and the medications that I hoped you have gone over and kind of assessed before class today. All right, I want to review some of the medications from week 4 that I hope you've looked at. Our first one is insulin aspart, or Novolog. It's on page 1119 in your Adams book. It's a short-acting hypoglycemic drug. This provides your patient a very rapid onset, more than regular, probably within 15 minutes. Onset is within 5 to 15 minutes. Peak is in about 1 to 3 hours, and duration is 3 to 5 hours. Always want to make sure the patient does have his meal there before you administer Novolog or insulin aspart, because there's always that chance the patient may become hypoglycemic if they don't eat soon. This can be a medication that can be given with intermittent or long-acting insulin. This is one of your prandial types of insulin where the healthcare provider may write a sliding scale, and this would be a type of insulin that may be used to cover the patient depending on what their blood sugars are. Obviously with insulin, we always want to know what our patient's blood sugars are, and we definitely want to make sure our patient is eating before we give the medication. And again, because we are giving insulin which reduces or lowers blood sugar, it's always important to watch for any signs of hypoglycemia, which occurs more often during the peak of how the insulin works. That would be within 1 to 3 hours after administration of the insulin. Again, this is a high alert medication, which now we are checking with 2 RNs to be sure that we're giving the correct insulin and the correct dosage. Okay, and along with any of our diabetics, we're always assessing electrolytes and other lab values which would be pertinent to the diabetic. Okay, if we're not seeing any good control, very important to communicate this to our physician. We may have to adjust the dosage or put them on a different or an added insulin to help control their blood glucoses. Remember, some of the medications that we give our patients may affect their blood glucose and may affect how well we can get those blood sugars controlled. If the sugars are real high, we want to check for ketones, because we want to hopefully prevent the patient from developing a diabetic emergency called DKA. The second medication is a regular insulin, okay, Novolog. Short-acting, onset is in about 30 to 60 minutes, peaks in about 2 to 4 hours, only lasts for about 5 to 7 hours. Again, pharmacologically, it's a short-acting hypoglycemic drug. Again, used for prandial coverage with our sliding scales. And again, many of the same provisions should be taken into consideration as with insulin aspart or Novolog. Okay, this is also on page 1119 in your Adams book. Again, we're always concerned about hypoglycemia and rebound hyperglycemia with the Somogyi phenomenon. where the blood sugar is good at HS at nighttime, but the patient goes to bed, but it drops too low at 4 a.m., and then again it spikes in the a.m. Again, anytime we're giving injections, we're always watching for any type of irritation or allergic response to the insulin, assessing the sites to make sure that we're using a variety of sites so that we're not giving it into the same spot all the time, because many times patients build up scar tissue, and that is a poor place for insulin to be absorbed. So we want to watch for accumulation of fat in the areas of injections. Again, assess your patients for any type of allergies, especially to beef or pork. So again, just always knowing what the blood sugar is before we administer insulin, checking it with another RN, and just kind of looking at the trend of how your patient's blood sugars have been running over the last 24 to 48 hours to see if we need to make any adjustments, add any type of insulin to his regimen to get his blood sugars under control, and see if there's any possibilities that medications could be affecting their blood glucose control. Okay. The next one is Glargine. May know that as Lantus. It's on page 1120. It's a gradual effect in about 1.1 hours. There is no peak with this, and it can be in effect up to 24 hours. It's a long-acting insulin, but it does provide a steady maintenance of blood sugars without providing any peak. It also helps to improve your patient's A1C and also help to bring down some of those lipids, their cholesterols, especially in your type 2 diabetics, because we see that as a common thread in our patients who have type 2. Because they've acquired type 2 diabetes, many of them follow that profile of metabolic syndrome, where they have high lipids, high blood pressure, they have that abdominal obesity, very much the qualities that unfortunately help them acquire type 2 diabetes. With Glargine, it's important that it's given the same time each day, and usually given once a day. There's no regard to meal timing, and this cannot be mixed with any other insulin. It's only given sub-Q, cannot be given by any other route. Again, if patients are receiving this and also on a sliding scale, just to be sure that we're really assessing blood sugars very carefully and monitoring them 4 times a day before meals and at HS. Now we're going to kind of switch gears. We've talked about the insulins. Now it's important that we look at the anti-diabetic medications. These are meds that we're going to give to our type 2 diabetics, because remember, if you understand the pathology behind type 2 diabetes versus type 1, our patients with type 2 still have some release of insulin from the pancreas, but not enough to control their blood sugars, thus making them hyperglycemic. With your type 1s, they have absolutely no pancreatic function and are totally dependent on insulin. So our first medication is glyburide, and this is an example of your sulfonylureas. It's on page 1125 in your Adams book. It helps lower blood glucose in our type 2 diabetics, and how it works is it stimulates the release of insulin from pancreatic beta cells and helps to increase the sensitivity of peripheral tissues to insulin. Okay, and of course, in order for this to be effective, there still has to be some beta cell function, meaning that the beta cells are still releasing somewhat of insulin. Obviously, since it's a med to lower blood glucose, one of the big side effects that can occur is hypoglycemia. Very rarely do we see our patients develop some of the blood dyscrasias of aplastic anemia, leukopenia, thrombocytopenia. Should not use with sulfa or thiazide diuretics, and of course use cautiously in our patients that have any renal or liver problems. Okay, Got to be careful with a lot of the herbal supplements that your patients may take, like ginseng or garlic or black cohosh. It could interfere with the action of glyburide, which is a sulfonylurea. Always check your med book, because sometimes with the medications that your patients may be on, there may be some drug interactions. There are some cardiac medications that our patients may be on that either enhance blood glucose or lower blood glucose. So it's always important to check what meds our patients are on when they're put on a sulfonylurea such as glyburide. Okay. The next one is in the pharmacological classification of a meglonide. Repaglinide is the prototype. It also lowers blood glucose in our type 2 diabetics, and how this works is by stimulating the release of insulin from the pancreatic beta cells. And again, we worry about hypoglycemia. Do not use in type 1, obviously. Again, be cautious with patients who are taking herbal supplements. And again, just watching blood glucose for the potential of hypoglycemia. Then your next pharmacological classification is your TZDs, and your prototype is rosiglitazone or Avandia. Again, lowers blood sugar, increases the cellular sensitivity to insulin, therefore reducing insulin resistance. And that's your type 2 diabetic's biggest problem, is insulin resistance. Again, hypoglycemia. Sometimes we see respiratory infections occur, sinusitis. These are just some not very frequent side effects. Patients do pretty good when they're on these anti-diabetic medications. How this works is, usually when a patient is first diagnosed with type 2 diabetes, they first assess their lifestyle. Many times, because the type 2 diabetics fit that profile of metabolic syndrome, a lot of them are overweight and obese. And many times if we get them to lose weight and start exercising and help lower their lipid levels, many times that helps keep their blood glucose in control. If that does not happen, then we usually start the diabetic or the type 2 diabetic on a oral anti-diabetic medication, usually one, okay, from one of these categories that we've talked about. We watch them for a couple weeks, make sure that they're adhering to how the medication has been ordered and they're taking it according to the way it was prescribed. And then we make sure our patients are keeping a journal of their blood glucose and adhering to diet, and if they've been instructed to exercise, that they're doing that as well. After 2 or 3 weeks, we watch them. If their blood sugars are still not where we would like them to be, they will add a second anti-diabetic medication, but it usually is from a different category. And then again, we watch them for a while, see how they do, and really teach our patients about the action of these drugs and even signs and symptoms of hypo as well as hyperglycemia, and what to do if they do have an hypoglycemic reaction. And then if the blood glucose is not as good as we would like it to be, they may add a third one, or maybe they might put the patient on some insulin because they don't seem to be adapting very well to the oral anti-diabetic medications, and we got to get that blood glucose down. So they may put them on a third, but usually a third is all they're going to do. If the patient doesn't respond well, or we don't get good patient outcomes from the third medication from, again, a different class, then we will put the patient on insulin. So Avandia is, again, like I said, you got to watch your patients that might have a history of cardiac issues, especially heart failure, because sometimes Avandia can worsen heart failure or increase the patient's risk of MI. This was a medication that was taken off the market a few years ago. Someone had died from an MI being on rosiglazone, and I'm sure the patient had a history of cardiac issues, and they took it off the market, but now they've got it back on, and it just is stated as a black box warning that if your patients do have cardiac issues, it can worsen heart failure and increase the risk of MI. There are some medications that you would not order this type of an anti-diabetic medications. Some of your antifungals, your angiotensin II receptors, your nitrates, thiazide diuretics, and things like that. Again, assessing what kind of herbal medications your patients might be on. It's important too to assess liver function in the beginning, and then they usually watch liver enzymes about every 3 to 6 months. Okay, and you know, I do want to tell you too that when your patients are put on these types of medications, we have also hopefully done some good nutritional teaching about how many calories the patient should be on, how many carbs and proteins and things like that. And they've been instructed well on where their calorie intake should be per day, depending on how active or how sedentary they are in their life, because all that combined will help the patients control their blood sugars much better. So those are some of the prototypes for the examples of those different classifications of anti-diabetic medications. Okay, the next couple drugs I'm going to talk about is some of your anti-anxiety disorders for insomnia, alprazolam or Xanax or diazepam, Valium, used for, those are benzodiazepines, used for anxiety, insomnia, seizure orders, and muscle spasms. A lot of times these are put on patients who might be trying to withdraw from alcohol dependence, just to help relax the patients, not be so fidgety when they're coming off of alcohol withdrawal. Valium we used to give a lot to patients as a pre-medication prior to maybe they're going down for a bronchoscopy or some kind of invasive procedure that we want to help the patient relax a little bit. Some of these drugs, you know, you got to be careful if patients are on them for a while, because they may lead to physical and psychological dependence. And if you kind of stop them abruptly or terminate their use abruptly, they can cause withdrawal symptoms such as headache, confusion, irritability, insomnia, and restlessness. You want to kind of get a history about their psych history, because some of the pre-existing depression or suicidal tendencies may worsen if your patients are on these kind of medications. And remember, they can make the patient very drowsy, so we worry about safety. So we want to monitor our patient's gait when ambulating. We want to assess level of consciousness to see if the patients are confused by being on these medications. And of course, because they sedate the patients, we definitely monitor their respiratory function as well as their blood pressure and heart rate. Too much of these medications can make your patient very sedated and put them in a state of respiratory depression. The next one is an anti-epileptic or a hydratoin neuronal sodium channel modulator called phenytoin or Dilantin. This is a common medication talked about on page 322 that is used for seizures, except absent seizures. Can also prevent seizures and eclampsia during neurosurgery, given during for someone with general convulsions during status epilepticus, and can be used also for patients that have VTAC due to digoxin, paroxysmal tachycardia. Can also be used for migraines, diabetic neuropathy, and neuropathic pain. How it works is it delays the influx of sodium ions in the neurons, the slowing of the propagation and spread of abnormal discharges. Again, you're trying to combat seizures, so some of the Side effects that we look for is confusion and ataxia, where the patient really has problems walking steady. Coma seizures can affect heart rhythm and cause the patient to develop bradycardia, VFib, or hypotension. Also, some of the blood dyscrasias, as I mentioned earlier, and some of the other medications like aplastic anemia, leukopenia, and thrombocytopenia, granulocytosis, and even some rashes. If you're giving Dilantin or phenytoin IV, it can cause serious hypotension and dysrhythmias. Other than that, ginkgo can decrease anti-seizure effectiveness. Again, always assessing our patients' labs, such as CBC and diff, renal and liver function. Increase diet intake of foods with vitamin K, D, and folic acid. It can also be used cautiously with patients with warfarin and oral contraceptives, as they can decrease their effectiveness. So we want to assess for any signs of bleeding. Any overdose with phenytoin is treated with activated charcoal and gastric lavage. The next medication is another anti-epileptic, carbamazepine or Tegretol, used for generalized tonic-clonic partial seizures with complex, not for absent seizures. This can also be used for patients who have acute mania associated with bipolar disease. Also treatment of pain associated with trigeminal neuralgia and neuropathic pain. And for a less serious problem, sometimes people that have prolonged hiccups, this has been a medication used to treat that, along with dementia with aggression and agitation. Again, inhibits sodium channels, blocking the repetitive, sustained firing of neurons that is characteristic of epilepsy. Being that it's to treat seizures, again, we look at any of the CNS effects, causing drowsiness, dizziness, ataxia, nausea, and vomiting. Again, the black box warning is aplastic anemia, a granulocytosis, fatal skin reactions such as epidermal necrosis and SJS. Okay. Other than that, those are probably some of the big side effects to look out for. Okay. And that is carbamazepine or Tegretol. The next one is a GABA analog or an anti-epileptic drug called gabapentin or Neurontin on page 326 in your book. Can also control partial seizures, can treat prostherpetic neuralgia and restless leg syndrome, neuropathic pain and hot flashes. We see it given for ALS and, again, trigeminal neuralgia and paresthesia, spasticity, and ocular ataxia in patients with MS. How it works is really unknown. It does not bind to the GABA receptors or to prevent endogenous GABA from binding. It does not bind to neurotransmitters such as serotonin, dopamine, glutamine, and histamines. Lightly affects the calcium channels, but not sure how. Again, watching for some of the CNS symptoms. Patients may have an increased frequency of viral infections, weight gain, and gastric upset. And do not use it pregnant or breastfeeding. And do not stop abruptly. You should titrate off. And when given with morphine or hydrocodone, your very potent opiates, it can increase CNS depression. And if you take it with ginkgo, it can decrease the anticonvulsant effect. Really nothing about labs, kind of pretty much what we discussed with some of the other anti-epileptic drugs. The next one is a GABA agonist, again, anti-epileptic drug, anti-maniac drug, valproic acid or Depicate. Treats epilepsy, prevents migraines, prevents mania and bipolar, and severe behavioral issues in patients with dementia, Alzheimer's, agitation that develop an explosive temper. Increases concentrations of the inhibitory neurotransmitter GABA in the brain. Abnormal neuron discharges are suppressed, leading to decreased seizures. The one thing that I see with valproic acid is, of course, again, CNS symptoms, and again, decreased platelets aggregation, so patients can have a situation of prolonged bleeding and clotting times. It can definitely cause bone marrow depression, causing the inhibition of many of our 3 primary cells to be produced. Photosensitivity, pulmonary edema, severe hepatotoxicity in patients that are less than 2 years old. Use cautiously with low serum albumin and renal impairment, and should not use if taking ETOH. Okay. Overdose, sedation, heart block, and coma can occur, so may give Narcan. Okay. May even have to do hemodialysis on the patient to rid the body of the toxic effects that are occurring. And that pretty much wraps up all the medications from this week. We'll talk about them in class and see if you have any questions. Make sure that you hit on the highlights of things that I've discussed with you. But at least this audio lecture gives you a little bit of preliminary learning about the meds and helps you get familiar with their names. I hope this helps, and I look forward to seeing you all in class, and you all have a great evening, and I'll talk to you soon.